Yeah, turn. Oh, sorry. Hold on.
Okay.
Good now.
So welcome to Core Competencies for Primary Behavioral Health Integration, Knowledge, Skills, and Attitudes. We have Dr. Bill Gunn here today, and he's actually going to introduce himself. So I'm just going to do a couple of quick housekeepings and then move forward. So we do have a roster for continuing education. It's going to pass around the room. Please sign this if you want continuing education. The CEs, once you sign in, you'll be emailed a SurveyMonkey link, and that can also be accessed off the conference website. They ask you to try to complete that within 2 weeks, and you'll be emailed a certificate within about a month. We also have continuing medical education and nursing education, and it's a little different process. For the sessions today in this room, please follow the instructions on this yellow piece of paper. You can find additional copies out in the entrance there. Same process, there's a SurveyMonkey. If you could please try to complete this by the end of the week or so, you will be emailed a certificate in about a month. There are no conflicts of interest to disclose for this particular session. And you all probably have been seeing, we are recording this session. It's going to be a webinar. The slides, as well as the webinar, will be on the North Country Health Consortium website. So if you could really help us to try to keep the noise level down, we'd appreciate it. And in this corner, you have a microphone over your head, so just to be cautious of that. So without any further ado, I just want to turn it over, and I believe you're going to take it from here.
Thanks, Open. Good morning. Good morning. Wish I had some conflicts to the stories.
You have
You could create some? What's that?
You must have some personal ones that
Thanks a lot. A heckler already. This is good. I haven't even said anything. Well, thanks for coming to this morning. And just as way of some introduction to this, and you'll see I'm standing here alone, even though it has Sandy Blount, who some of you know, on the program. He had some health-related issues and was not able to come. So it won't hurt my feelings if you were here to see him. You can leave now and you can take their names as they go out. But Sandy and I talked last night, and it was interesting actually, our slides, we kind of both put them in, and even though we've sort of worked in parallel, presenting some together over the years, because we were both pretty old, and it really dovetailed well, and so I think hopefully I can do him justice, and I have a little video of him later on, just so you can see who that was. So again, I'm Bill Gunn. I started out as a school psychologist, actually, early career. So I was very used to working in schools and with teachers and getting these referrals to go to testing to the teachers and the kids and the parents to be calling, and administrators. So working in a system where everybody's got different roles and you're trying to figure out how to navigate those teams, IEP meetings, that kind of thing. So, and when I went back to get, after that, for about 4 or 5 years, and went back to finish a doctoral degree, I started out in a psychology program. It really wasn't appealing. I took a couple of family therapy courses and sort of got hooked. Ended up spending another couple of years, a lot more money, finishing that degree. But I think the interest in families and trying to get, much like schools, you got a group of people with a common purpose trying to move forward together. It felt similar to me. So I've always been interested in the kind of connections between things and that are as important as the things themselves, the people themselves. So I think that's what drew me then to an internship in, or it really ended up being a first job in family medicine. This was in Virginia in the late 80s, and I had no idea what family medicine was or why they would even be interested in listening to me or what this was all about, and spent a couple of years trying to figure out how to get out of it because of the pace and the The culture seemed different. These were residents in training, so they were there for 3 years. The faculty were sitting referrals. It was just felt like a chaotic environment at that time. I couldn't even see the patterns. They were asking for advice on big charts. We had paper charts then, and they had less than 5 minutes. So, but 30 years later, I spent all that time in training in family medicine in different parts of the country. 20 years in Concord at the New Hampshire Government Family Medicine Residency Program. And so that sort of building on those things, and it's sort of been a personal interest. Maybe there's a diagnosis in there for me. My wife would probably say that. But just the chaos and trying to figure out how to help very complicated situations and help physicians, who most primary care physicians they feel responsible, or primary care providers, I should say, feel responsible for providing good care for all of health, certainly family medicine, that's how it started. So they want to be helpful, and yet the time and expertise and the sort of culture that we've set up, the medical system particularly, is difficult for them to do that. So I have worked for years in trying to figure out how to partner with them, how to train other people to partner with them. And so it's really gratifying to see what's happened over those years, particularly in the last 5 or 10 years, that the focus on primary care integration was not always that way. There were a long time of that was, why should we do it? And more of the question now is, how do we do it? Sandy, I will mention Sandy Blount. I started about 5 years before he did. He spent all of his time at UMass. Most of his career, he left there, transitioned, as we'll say. Retired is not really the right word, but both of us have transitioned into different kinds of work. And Sandy is at Antioch University now, and some of you may know or followed his work. He's written some books around integrated primary care, and is a real fervent advocate for the role of behavioral health in primary care, and really regrets not being able to be here today. So let me just get a sense first. How many people know what the IDNs are? Oh, thank you. Well, look at this. This is great. How many people don't? Yeah, well, you've either been to workshops yesterday or we've sort of been beaten over the head for the last 2.5 years about this. So currently I've transitioned into clinical lead with the IDN 6, which is the Seacoast area. I see some homies out there from the Seacoast. How many people are in Region 1, which is, this would be a real test of whether you know which region you're in. There's, great. How about Region 2, Concord area? Good, all right. What's that?
Thanks for identifying too as Concord.
Yes. Region 3, there's the test. Nashua. Yeah, got some Nashua. How about Region 4? Manchester, and Region 5. In the Lakes area, and Region 6, and some folks here, great, and 7. Great, so we represent people from all over the state, that's great. How many here are nurses in primary care? 1? Great, thank you. How about medical assistants? Not likely. PAs? Primary care doctors? Interesting. Most of these talks, even though they are believers in this, they don't sort of come to these kind of conferences unless they're sort of directly invited. So, how about clinicians working now in a primary care setting? Great. And how about, we'll use this word, you'll hear it some more, is care enhancers. Either working within a primary care setting or out in the community. I know some of you folks are enhancing the care, social determinants issues, working in agencies, and you can be multiple roles. How about leadership? Great. Patient advocates. I see a couple of the strongest in the state sitting right back there. This is intimidating. So a lot of different variety, folks. So that's. So let me go into the slides, and certainly, even though this is not a room designed particularly for interaction, and we're going to try to do something at the end to break it up a little bit. If you have a comment, if you have a question, I would much rather not just keep droning on if you feel like, oh, let me just respond to that. So please raise your hands. And these slides, as April said, will all be available.
I don't know if the slide.
Okay. So Sandy and I were asked, we had a group that got together to create an IDN track. And some of you may have gone to some of the other talks that the IDN is sponsoring, and then we're recording them, obviously, putting them on the webinar. And part of our task is to, of the IDN work, is to provide enough training opportunities to understand what are the roles. There are a number of training opportunities, but this one is the role of behavioral health in primary care, or providers who are from mental health centers who go into primary care, what's known sometimes as reverse integration, but they would say the other is reverse. So there's room for both. The continuum is really what's important. I believe, and I'll try to make the case for, we really need a lot more of a generalist specialty within primary care. And many of you are working in those kind of settings. So in order to provide biopsychosocial care, most people have heard this biopsychosocial term. It sort of is the hallmark, and certainly in family medicine, that was sort of how it started. And I think what's key here is the medical system, and I have a physician colleague that I work with, and I'll talk about his study in a little bit, Andy Valeras up in Concord, who will talk about the sort of failures of our biomedical model. And we've sort of heard that a lot. The biomedical model is really designed well for simple problems in a mental health world. You might see it as adjustment reactions. You can kind of see it getting better. There's sort of a course and somewhat of a protocol at times to sort of make things better. In a medical world, strep throat is a great example. Come in and it's a pretty straightforward kind of approach. But many of the issues that we're all seeing are much more complicated than that, or even complex, in that you don't really, the word complicated often is, so you need a very, it could be hip surgery is very complicated, but if you follow the algorithm, usually you get good results. I'm here walking around, so I can testify to that. But when you but raising children, how many people have kids already? So how many people, all their kids, they do the same thing with all 1, 2, 3 kids, and it all turns out the same way? Not even close, right? So that's the definition of complex. When you're not sure what's going to happen, there's a multitude of factors going on with social issues, social determinants. So that the biopsychosocial care really requires a team, and we're going to talk some about that. A couple of efforts to define what these behavioral health competencies are, and some of the training and supervision that's a little bit different would make the case in a primary care setting. So take a look at this. This is a bit of a projected test. I don't know if you can see them. I think they're kind of pretty small. So in the middle, you see patients and families, and you got concentric circles. So you have community health workers. There are plenty of other roles that could be on here. Medical office assistants, patient representatives, people at the front desk. I'm looking at a primary care kind of setting. You get farther out, you get the sort of clinical, quote unquote, licensed or license eligible folks. And on the far outside, board of directors, chief of operations, human resources. So there are a number of people out there on the far end of that. So what strikes you in that? Anything this is like a Rorschach like this. What strikes you? Integration? So the focus in the middle, patients and families. It is very, and I fall into this myself too, you get so involved in models of care, all of a sudden you go, where's the patient? And in my view, where's the family? That is really often the primary caregivers and primary folks. So, yes, what did you notice?
I was going to say that the higher it goes in the hierarchy, medical director, the farther away from the patient they get.
Yes, right. I mean, that from the day-to-day of patients, not that they're not involved in it, but you're right. The people closest to, this is designed to say that people in the circles closest to the patients and families. You could put a lot of the folks that work in our communities with, say, homeless outreach, housing agencies, welfare systems. Having gone into Region 6 and being really, my eyes opened a little bit to the world outside of primary care. I knew all that was out there. If any of you went to the talk by Tori Jennison and Sandy in Concord yesterday, you got a sense of sort of trying to bring those folks under the tent. So those are the folks that are seeing the patients and families way more than in primary care, because there are a lot of people that don't even come into primary care. We often only talk about the people we see, not the 30, 40% of people on the primary care roles that never come in. But they're out there and they're seeing folks closest to them. So why not involve them? Anything else that you noticed? You have in the circle, sometimes in these circles, the financial folks, so the chief financial officer of an organization, the CEOs, the C-suite folks are kind of not included in this. It's sort of like they're not kind of part of it. They absolutely are. There's some in here I know now that really sort of see, without our support, without our sort of really efforts and taking taking charge of being involved in this, it's not going to happen. So they need to be in the circle. And clinicians, for a long time, I think that's changing some now. When I just do the clinical work, I let somebody else worry about the operations and the money. And the administrative operations people are going, well, it's never going to happen in this kind of workflow. The financial people are going, how are we going to pay for this? So without all three of those worlds talking to each other, not much happens. So the other, let me just sort of, so patients in the family, everybody has a role. So the point of these couple slides is to say, most of this talk is about the behavioral health role and the care enhancer role. But that the medical assistants, that's why I asked if there happened to be any here, the nurses in primary care settings, they know patients and families sometimes way better than the clinicians do. They will tell them sometimes things they won't tell clinicians. They're known by them. So how to bring them in and have them play a behavioral health role? There's, at its extreme, if a nurse or a medical assistant says, uh-oh, there are tears, got to call behavioral health. That's probably not a great first-line response, right? We all know how to respond to tears by moving towards somebody, not, let me call somebody you can talk to. I had a resident, I was watching a resident see a patient, and he came out. I said, come on out and let's talk about it first before you go back in. And he said, he needs to talk to somebody. He's talking to you, and he does not want to talk to anybody else. You're it. Now let's talk about how you can kind of be present with him now. Now that's not to say at a time where does that need to then bring in a team member, a behavioral health team member to bring them in, not to sort of push them away. So, the coordination between roles is critical as the roles themselves. Again, the connection, and I mentioned about leadership. So this was a project that I mentioned Dr. Valeras before, who's in Concord. He's now the director of Preventive Medicine Leadership Program. And for his MPH through Dartmouth, he wanted to really try to reduce the emergency room utilization from our health center. And it's the Concord Family Health Center. It's not an FQHC, but it would be if we weren't sort of part of, if they weren't part of the, 20 years it's hard to get away from weren't involved with Concord Hospital. But the idea was to try to figure out how come folks go to the ER when we're open, or go in the middle of the night when, a phone call, they weren't reassured. They'll call up and we'll talk to them, and they still go to the ER. Okay? So how do we bring them in? So he did a great project where we identified people, I think it was 4 or 5 visits in the last year, and we invited them to come in. It was a very tricky thing, because you don't want people to come in and you go, how come you've been going to the ER so much? This is not a punishing thing, right? So it was more, we need to understand why we're not serving you best. So we had a patient focus group that he and I helped co-facilitate this. We had 7, 8 patients who came in. First of all, they didn't even know we were a residency, a lot of them. They didn't know a lot of things that we just took for granted. And they really helped us try to figure out how could we help them better. We had a care plan in our electronic medical record. And we had one little section of it that was called the UPOC, Urgent Plan of Care, which wasn't used that much, but we used that piece to identify folks, and we said, help us understand when you call, what do you want us to do? How can we work together so you don't have to go to the ER? Not many people wanted to go, they just felt like, I know they're open, I know I'll get seen, and I'm used to doing that. So how can we be a better service to you? Because they were over-serviced and underserved, because they were often frustrated by what they got in the ER. And so then we talked to those folks, we put that in the electronic record, and then and it ended up being, I think there were about 25 to 30 people in the sample of the quote-unquote high utilizers, and 50% reduction in ER utilization over that next year, which was pretty, it was a small sample, but I think when we facilitated a conversation with the team who was involved, there was just one little pod of, a few physicians, medical assistants, nurses, and the physicians, these were resident physicians, said, it really helped me when somebody called at night, I could look at the chart and said, what's your cat's name, or what do you want us to do? It was written in there what to ask them, what their kind of care plan was when they were in crisis. That personal touch really made a huge difference to the provider. That was kind of surprising. Many of the patients reduced utilization. Providers changed their attitude by, why is this person, this is not an emergency. Why are they calling me in the middle of the night? To, I understand, this person lives alone. Their dog just died. I remember one case, and she was really alone then, without, so it was that personal sense that I think made the difference. All right, but the change was not, behavioral health was involved. Obviously, I was pretty involved in kind of planning and but it felt like on the periphery. This was really an intervention by nurses and medical assistants creating these plans. So the point is more that it's not just the behavioral health folks we need to kind of call. Sandy's great at saying, medical providers are comfortable with all bodily fluids except one. What do you think? Tears. I, on the other hand, you would say, only all the rest of that stuff. Tears are fine with me, the rest of it, forget it. Okay, so I'm going to switch over now to the specific roles and what's been done about competencies of folks coming into primary care. So on the left you see it says a paucity of training. So most mental health providers don't have the background or specific training to practice in integrated care. It takes specific training and effort to, like I said, 2 years for me trying to figure out how to get out of it. I've seen many folks go in and feel like, this just isn't my cup of tea, which is not a problem because there's plenty to go around. Workforce, as we all know, is one of the biggest issues here. So we need specialty behavioral health providers. We need, but I would argue, need more folks really closer to the action in primary care. I saw folks in primary care that I would never have seen in a mental health setting. People with multiple unexplained physical symptoms, obviously they're not going to go. They're going, you saying my irritable bowel syndrome or my headaches, or I got to go see a shrink. No, I'm not doing that. But yeah, I'll see this guy in your office who kind of works with you. So, if you're not trained, the real tendency is to kind of fall back into the model how most of us in mental health were trained in 50-minute hours, which is really a convenient time frame because then you can write a note for 10 minutes and then you're ready for the next session. I'm not sure it's always what's necessary for patients, certainly in primary care. And the adjustments have to work in fast-paced, team-based settings. So it just needs new skills, is the point of this slide. So it's really different from mental health. So many of you have seen this model presented before. The thing I don't like about this is that really this was designed by a colleague who's in the VA. And the VA and the Department of Defense particularly have gone all in with integrated primary care. All of their primary care clinics, not that they're perfect, but they are a single payer system. We are the payer. They have the whole thing there. So it makes it easier for them, but they have really gone all in with this. I'm sorry the slide is so small. We'll be able to see it, or else Mike's having a hard time reading right there. The heckler back there, I just want to call you out a little bit. So. But it presents it as if there's a big line in the middle, it's this or that. I think there's a lot in the middle there that are hybrid models. But on the left, you see sort of this new role that we're talking about, where the focus is on the clinic. What's really easy to say and hard to actualize is that, if I'm in a primary care clinic, I am responsible for 6,000 patients, which is kind of a daunting idea as opposed to a caseload of 30, right? That it's really collaborative, it's ongoing support. There's shorter appointments often to really focus on function, what's happening now. Why are you coming in now? Let's focus on sleep. Very functional, present focused problems. See if we can make some difference in anxiety levels or depression, before moving it up to another level of care. Very solution focused. Been a lot of debate, as you can imagine, on the treatment plan leader, that the primary care team physician is the leader in this kind of model. And you see the support overall health of the veteran population, so you can see where that comes from the VA. And the responsibility remains with the primary care group. The mental health specialty is kind of what we're used to more. Now, and some of you have seen Cherokee Health Systems as another example of this left side. They've kind of gone all in with this. It's a FQHC in Tennessee, and they started as a mental health center and evolved into a large system of primary care clinics and mental health clinics. Kaiser Permanente. I think there's something about having the financial and the operational and the clinical part all together. Doesn't make it perfect, but it makes it easier. For example, I heard in Oregon, they don't have MCOs like we do here. They have 16 CCOs, community care organizations. They're the MCO, the payers in Oregon. They're 4 times our size. They have 16 of them, which they would say is probably too many. They need to bring some together. But they have paired their CCOs with a geographic region. So let's say we had an MCO who was just on the seacoast. It really created the opportunity for a lot of partnerships with the payer, which I think is somewhat of it's harder to do when you have 2, soon to be 3 MCOs who are part of the whole, trying to cover the whole state. So I don't think there's as much in Concord. We had a lot of, we had social workers who did this left side role, but we had 4 clinicians who did the right side role in the same building. So it was who would, if somebody really identified trauma-based issues as really needing a lot of focus right now, the patient wanted it, we had somewhere to go internally to be able to, for them to be seen. So I think there are a lot of places that it's not either or, it's sort of both and. So I'm just going to show you, there are 2 efforts I'm going to show you to try to look at the competencies for these roles of behavioral health folks in primary care. Now I will say, and I will say it other times too, that there's a lot of focus on training the behavioral health person there. There is much less on training the medical teams and providers to work with us, with the behavioral health folks. Okay, so it's no wonder that when they think, sometimes what's the role? Well, I just refer to them. I refer to cardiology, I refer to pulmonology, so I'm just going to refer to them, anything that has anxiety and depression in it. I actually think those are one word now, anxiety, depression. Or as a cynical psychiatrist I worked with said, they're just two big buckets. Sometimes you have both buckets, but they're driven by the pharmaceutical industry, and I won't go down that road. But these are two efforts. I think there needs to be a lot more work of helping the primary care teams learn how to work in this model, and there's not enough. But again, back to focusing on the providers themselves. So these were the areas. I'm just going to hit them lightly, all 6 of those areas. So now we're into the behavioral health competencies, which is the knowledge, skills, and attitudes. Attitudes tends to be a big deal in this. I think more than other things, because again, that sense of potential marginalization, not feeling a part of the team, is really possible. So these are some of the things: recognizing names of appropriate doses of medication. So it doesn't mean they're prescribing, obviously, or talking about side effects, but it means if Sue sends me a patient and I'm talking to them about, I look at the chart and I see what they're on and I say, do you have any side effects in this that I could let your provider know? A lot of people will stop the medications and don't come back. And you go, well, I stopped it the first week, the side effects bothered me. Well, that would have been nice to know. So I think we can partner, and so knowing about medical conditions, that's why I think Tracy Tinker's coming this afternoon to talk about chronic medical conditions, to learn. So you're familiar with that language, so that I can be as familiar talking about biological language. The flip side of that is I think the providers, I'm trying to train this to say, can you reinforce exercise? Because we talked about it as a plan. Medical providers go, oh, I see in here that that's your plan. How's that going for you? So that we're really complementing each other. Research and evaluation is another role that often behavioral health folks play in primary care. And PDSA cycles, how many people are familiar at this point in time with plan, use, study, act? These quick cycle turnarounds that we can be involved in. I would say that Andy's was a little bit longer, but that's the kind of project that we were involved in trying to, about ER utilization. Another one that comes to mind is around no-shows. Pretty much every primary care clinic goes through cycles of, we need to do something about the no-show rate, which seems, depending on where you are, it's 15, 20%, despite multiple calls. Although I wonder about the calls. I had somebody come in and say, well, I didn't get a call, so I didn't know to come. We talked about, you had an appointment. Well, I didn't get the call. So we trained people to rely on, it was like that was the, did you write it down? Yeah, but I didn't get the call. So improving no-show rates, I think, is something a behavioral health person can be involved in planning and trying to figure out and be part of a workflow. Not totally. SBIRT, many people are involved in SBIRT programs, yeah. Similar kind of thing. It's an improvement strategy trying to identify early on and prevent substance use. They talked about systems. So there's a lot of focus on leadership, working with teams, advocacy. And this is not, if somebody comes in as a student or a beginning person working in behavioral health, it's not what they're going to start doing right away, but the idea of being involved in advocacy efforts around codes that are able to be used through at least knowing what's happened. There are health and behavior codes. We were talking this morning. I don't know if Val's here or not, but we were talking about codes that are, it sounds like they're health and behavior codes. Anybody familiar with these codes? So they were designed by psychologists. Somehow, only psychologists can bill for these in New Hampshire, but many states, social workers can bill. These are CPT codes, and the idea of them is that if somebody comes to me and they're really having trouble managing their hypertension medication or diabetes, or they're really not, and I'm seeing them and trying to help with trying to figure out how to have a better adherence policy to those medications. The CPT code I would use is diabetes or hypertension. And then the procedure is this intervention. So it's just an example of a policy. There are a lot of policies like that, I think, that could be advocated for. Talked about the fast, professionalism was their third link. Ethics, particular attention to dual relationships, confidentiality, informed consent. It goes beyond, this is a whole talk in itself. Some of you may have been at that. I think Lucy Hutter is next door or somewhere right around here talking right now about some of this. She's certainly our expert around the informed consent issues in the state, I think, and looking at, particularly around substance use consents, but these come up in different ways in primary care. We meaning the IDN, placed somebody in a pediatric practice, and right away she had a provider come to her and say, can I talk about my son? Will you see my son? And an administrator at a hospital come in who was involved in this clinic say, can you see us as a family? It's like, whoa, I don't know. Let me figure this out. So I think you can work through them, just different things come up, I guess is my point. Relationships was their first, was part of that. Understands the roles of other team members. There's some work by, this is sort of a, if you want more information on any of these things I'm kind of flying through, just in the interest of time, let me know. There's some work by Jody Hoffer-Gattel, who happens to live in Portsmouth, written a couple books and teaches at Brandeis, really about the criticalness of relational coordination, and has done some pretty good work, I think, in looking at what does it take for a team to be effective and get, she started her work with Southwest Airlines. I love Southwest, anybody fly Southwest? Why do the airlines get off on time more than other airlines? So that was her dissertation, was studying the differences. One of the things she found, and so she identified these characteristics of teams, and now she's applying a lot of this to healthcare settings, and there's been a lot of work going on nationally to try to provide some evidence, some stronger and stronger evidence for what are the specific things that teams need to do to really get the planes off on time. In this case, to get patients and families feeling satisfied. And as you might imagine, they have to do with shared goals, so we're all on the same page about, in this case, I would say the patient and family and what we're doing. There's shared knowledge, and that was the one that Southwest stood out on. The baggage people knew what the challenges were at the check-in desk, and so they were in communication and knew what the roles were. It wasn't just, I did my job, must be their problem, right? So if you think about healthcare, that can happen. Certainly within an agency or the community, but outside, certainly between agencies. We had many meetings with our local mental health folks at Riverbend over, because it's very easy to go, well, they didn't accept them, why not? So it must be their problem. And I'm sure they had stories with us as well. So getting together and figuring out what are the challenges you face. So that's a key piece, that shared knowledge, mutual respect, and communication styles. Those were some of the elements. And the science that she's developing is called relational coordination. So you can Google it. I think it's fascinating, very applicable for the kind of work that we're trying to do with the IDNs in developing skills in this. This is more the clinical application of what you do in the room with people, the shorter visits, providing consultation, some brief assessment and intervention. Comfortable with the role of expert, which is, if a provider says, well, I have an expert in sleep here, who's going to come in, and I used to think, I don't know about an expert, but in the primary care world of presenting, we'll figure it out. If we're not able to do it, then we can look for sort of other resources. But often it's that attention, it's that being in one setting that made a difference. And the last one was around education. So coaching medical providers and staff, education. So all 6 of these areas, the article from the American Psychologist, each one of these areas, I'm just sort of hitting the highlight, drilled down into specific behavioral competencies. I've kind of done one, these are examples of those that I've gone through, but there are many more there. And it sort of gives a planning if you have somebody who's starting or you're trying to train somebody to work in a primary care clinic, What is it that they need to learn? It's a good resource to look at sort of how to train them. So switching a little bit to supervision, just to highlight some of the similarities and differences. So what's the same? When I've trained early on, when I was working in primary care, my mentor, a psychologist named Dave Waters at the University of Virginia, said the only way I've been able to really feel like stay in this for 30 years is to be able to train my own kind, which is not probably the way to say it, but have behavioral health folks to get more of us involved in this. So I started right away doing that. Every setting I was in, we had pretty robust training programs. So, and we all met just like with 1 hour a week, training them. We were focused on the quality of patient care. You know, I'd get a list of who they were seeing. It was a pretty, you know, traditional kind of supervision model. It's always better to have volunteers working in primary care than not. And we did what, you know, you would typically do. If a learner came in and had a lot of experience, you would change your, you know, supervision style depending on what they needed. What's different in primary care, I think that the hour plus, and this is, you know, potentially expensive, but I would sit in the room with providers, and so that I could be available. There's somebody within a training program for physicians. There's always somebody physically there to precept, they call it, supervise whatever they're seeing. So I would stay in there for half a day, and you know, do other things too, but be available on the fly. Because I think it's very hard. It matches the pace, so it's a precepting kind of a model. So we can focus on the patient care, plus some of those things I just referenced about working with a team. There's always, you know, this, it sounds really good, 30 minutes you do this quick assessment out, but it is harder than it looks. And sometimes it's, you know, it doesn't, keeping focused and not being pulled into the stories that, you know, most of us went to school for the stories. We want to hear and be able to understand what people have gone through to be able to help them. So it's very hard to sort of listen to that and pay attention to that, but keep it focused and keep it moving to be available for other folks who are coming in. So, assess for different kind of competencies they talked about. So the same, you'd be, you know, goals, disciplines provide supervision to their own, which is not a great, I think that's changing a little bit, I hope so. I was never able to provide any supervision to social workers working in there because we all the guilds had their own kind of silos about how they were trained. That's changed a little bit, I think, in different states, and I think the rules here changed a little bit last year to be able to provide some of that, which is good, I think. Video is always better than audio, is better than case reports. So those are the things that are the same. In different, most of these are similar, that it's going to be challenging. Check-ins even more important. So even though it was 1 hour a week, there was frequent kind of time, you know, with them talking about how's it working in this culture and what are you running into. Often there was a sense of marginalization, and that took a while to, you know, you don't really feel like you're kind of, you know, if you're a learner and you've been trained in multiple kind of, you know, mental health strategies, CBT, you have sort of a professional sort of sense of who you are and what you're doing, and you're sitting in there and it feels like you're kind of being ignored. Things are spinning around you, patients are coming in, things are happening, and the potential to feel marginalized a little bit is pretty high, naturally, I think. So some strategies then are, I love this perching, the one at the bottom there. You're kind of just, you know, these are usually very small spaces. And so you're usually kind of hanging out somewhere, you know, just sort of, you know, just watching the flow and seeing what's happening. And at times, when you, as opposed to waiting in your office for the phone to ring. So being involved in the milieu there. Be the water. Don't expect the site to make big changes, because often, you know, it's not like you can come in and they're going, we've been waiting for you and you can do exactly what's been described here. And working with those who want to work with you. There's, you know, most medical providers I think are interested, but there's a variability, like in anything. in terms of how much they really are involved and want to involve you in part of the team. Sometimes you would just like to refer out to you, so now I'm talking to you as if you're the behavioral health folks, and this is the kind of training that would be sort of needed. A lot of shadowing. And these are more of the same. Training in IPC consists of training with other. This is really a reference to, which doesn't happen near enough. I think that you're trained as a team as opposed to only trained in guilds, because we're back to the siloing again, I think. But this is easy to talk about, and everybody talks about it, about how to do that in real time, how to get the teams involved is not easy. We have, for example, for pediatrics, there's been a curriculum developed for teams to come to 2 one-day settings, and I'm trying to get a couple of our IDN teams to go together. So you get a medical provider, a nurse, potential MA, and a behavioral health folks, and they're trained together. How are we going to work together? And that, I think, is going to be a really, it's costly, but I think you sort of pay now or pay later in terms of the kind of potential that can be developed from that. Some of the challenges of this, there's a tendency to creep back to mental health services. Documentation differences, and again, I won't go into, we can talk later about that, the difference in progress notes and psychotherapy notes. Uh-oh, time's up. The progress notes, everybody writes progress notes, so they're not in the same category as psychotherapy notes. So they're very brief, they're very focused on sort of what's needed in that particular time. So I want to go through a couple of Sandy's slides, and we're going to switch to April. Maybe you can help me do this. So most of what I've talked about are sort of trainees and what these were developed. This and the more kind of graduate students, early learners. Sandy's really focused, and I'll talk about it a little more, on he has some, well, I'll reference him a little bit, but he was involved in a project in Colorado that had a different group that formed it. The one I talked about was the American Psychological Association. They had experts from the VA, the Department of Defense, and about 15 different organizations each sent 2 experts to create those competencies I talked about. This one was this was a different effort. This was in Colorado, and they did a consensus. So they got, I'll let him describe it. Sandy, we're going to have a little video of Sandy talking about how this was developed. But here you see very similar things. Their consensus was identifying, I know you can't see that, sorry about it. Behavioral health needs as part of a team, engaging patients in their care, which was more present in this one than the one I just showed you. So I think coming back to those roots, communicating. So a lot of these are similar, but it was a different process of getting to them. So, you mind doing that? This is just a 2-minute clip that sort of promotes that.
Maybe you're new to integrating behavioral health into primary care and want to develop the necessary expertise. Maybe you're already delivering integrated primary care, but want to deepen your abilities. Wherever you are in the process, it's important to have the right skills for the right settings. The 8 competencies can help, but before we get into how to use them, let's take a step back. How do these competencies come to be? More importantly, how do they improve our fragmented system? In 2015, a team of experienced clinicians, educators, and administrators convened and outlined a range of things licensed behavioral health clinicians do in primary care that make integrated teams effective. The thought being, if everyone understands the skills and expertise clinicians bring to the table, team members will know what to expect from each other and how to support one another. The result? Teams that treat mental and physical health conditions together. Now, the competencies aren't some rigid checklist. Instead, think of this tool as a living, breathing document. It will evolve over time, and it should be applied based on your clinic's workflows to meet the needs of your patients. Which brings me to implementation. There's no one right way. A great place to start is to dive into our tools and videos. Evaluate team needs with your colleagues and jot down where you can go. You're putting this into practice, and together, we're achieving better patient outcomes from the beginning.
Any thoughts so far before I got a few more of this slide I was going to show you? Any questions or comments?
Bill?
Yeah.
Hey, Bill, I have a question, or a comment, both. You talked a lot about these competencies, which ideally really means changing the culture.
Do people hear?
You talked a great deal about the competencies that are needed, but I think it's really about changing the culture within the organization. So could you talk a little bit about what kind of time frame we're talking about to make these kind of changes, as well as resources that might be needed to make these changes?
Well, I think the time frame, I mean, it feels ongoing to me. I mean, I absolutely agree with you. The culture, you know, I think it's both cultures sort of needing to change together. I think there's, I think some of these resources are available. There's an organization called the Collaborative Family Healthcare Association that is sort of the, you know, it's not focused on a guild. It's focused on the idea of this, of integrated care, both in primary care and into mental health centers. So I think that's a good resource. There's a journal that comes out of that called Family Systems and Health. So there's a lot of talk in there about how do you change a, you know, culture from this fragmentation. I think the team training part, I think really figuring out, but that takes leadership to say most times, particularly with medical providers, to say, can they have X time out of clinic to develop this, is that really pushes against the, you know, financial business models, which I totally get. So it takes a really buy-in from leadership, I think, to sort of be able to do that. No more.
You talked about shared goals, shared knowledge, mutual respect as being ways to kind of see integration start to work. And I would also say that one of my experience was...
Have you read them? Where you are?
Oh, I'm a pediatric behavioral health clinician at Child Health Services in Manchester. And one of the things that I found really was helpful was this change in culture for behavioral health also being shadowed, and this idea of not expecting the PCPs to really understand what value you bring until they witness it, and there's that kind of handoff, not a handoff, but more of a, you know, you're in the room together often, and they can gain confidence by just seeing you in action. And I think that's not part of the culture of behavioral health or mental health clinicians to, you know, be with a patient and having other providers there with them. So I know that in our practice, when we were able to just, so the perching is important, but I think inserting to just kind of finding a way in the room with the provider, and maybe that, you know, we talked about that beforehand, what are the ways that you can get in the room with them to help them to see you in action, and then they can kind of step back.
So moving to what Sandy's role is now. So these are some of Sandy's slides from, this is now the Endowment for Health has funded, and going back even one more step, Cherokee Health Systems came up, I don't know, it was 5 years ago maybe, and did kind of a quick state of the state. It was, you know, I was part of that with the endowment, and they we probably could have given more time, some things could have been done, it wasn't, but it did spark a lot of conversation about this, about integrated care in communities. And I think of it now as a, you know, in IDN 6, we really have 4 large communities with people trying to work together, you know, roughly based on the 4 hospital systems in our region. So I think of it a lot about, we use the word neighborhood a lot, and really trying to improve the relationships throughout the neighborhood about this, not just only within a clinic. But the focus, the thing was identified by the Cherokee report that came out of that, was around financial modeling, was around sort of clinical development, and around workforce. Those were 3 areas that were identified. And the Citizens Health Initiative took those first 2, and Antioch, and led by Sandy's efforts, took the workforce issues. So some of this is that work focused on primary care behavioral health workforce, how we deliver that to the most stressed populations, those complex patients and families situations I talked about. He studied the safety net clinics, which are the FQHCs, and lookalikes, you know, there was lookalike FQHCs, which I'm not sure we have any in the state anymore. Mid-state was one. Most of them are FQHCs. There are 10, I think, in the state now.
13.
13? Great. And looked at how well the training infrastructure of the state is poised to produce the workforce. So they, I think they looked at, this is the SAMHSA continuum that all of us have, I assume, have seen at this point, from coordinated to integrated. And the point he said he made in this, you can't see it at the bottom, that they asked those FQHCs to what extent where are you on this, using I'm not sure which scale they did. We've used a scale from Maine, but it was basically one that looked at the elements of integration. And the provider self-report was over on the right at level 5, just barely level 5. The observer, I don't know who the observers were, came in, it was much less than that, which, you know, the elements, I think of that, are people who, you know, I said, what's an example of that? And he said, you know, that just having somebody co-located in there and somebody to refer to, people went, oh, we're pretty high on this scale then, because we have somebody we can refer to them. But they weren't doing a lot of the elements on those scales that I just sort of talked through. So it's just that kind of perception. When Cherokee came, they came to our clinic, and we would have scored just like this. We went, we're pretty good. You know, we're doing a lot of this stuff, but some of the details of actually in the day-to-day, if you watched it, it probably, you know, it was probably less than we would have liked to have thought. So that was his point in that. So then they defined behavioral health broadly. So number 1 there is prescribing and consulting. So that's a psychiatric, you know, psychotropic medications. So, you know, that's a role-based thing. My general feeling about medications is there are not enough. Certainly not enough psychiatrists or child psychiatrists, particularly in any area, not just in New Hampshire, but in the country as a whole. That probably the best model is having a consulting psychiatrist who doesn't write prescriptions, who sees and recommends and consults and provides, because then they can be much more available to the primary care providers and enhance their skills. And that's what we had in Concord. We had a psychiatrist who didn't write one prescription. Sasha Kuftanek is her name, but she does one or sometimes a follow-up consultation and then follows them with the primary care folks, which is really helpful to have it right there, because when Plan A doesn't work, which a lot of times Plan A doesn't work, what do you do for Plan B? So there are, it's great now that nurse practitioners and PAs are able to be, you know, trained to provide these kind of services. So I think we need more of that. Number 2 then is the consulting with PCPs and other team members about patient needs, which is more of the social work, licensed person, psychology, things I've just been talking about. The rest of them, if you look at providing behavioral interventions about substance use needs and health behavior change, patient engagement, addressing health literacy, keeping information about patient health needs and behavior flowing, and addressing social determinants. Those are different roles. Somebody else, other people can do those roles. So this is how Antioch defined what they heard from the FQHCs about sort of what's needed. The first two are kind of more what we typically think of, but there's 5 more of those in terms of what the impact is on overall health. So they took that list and put them into these broad buckets, if you will. So the bottom one being what we were just talking about, were the competencies that I was referencing. The middle one I just mentioned in terms of and then the care enhancers. So these are folks who are connectors, enhancing the care, and they have a lot of names that go with them, and that's part of our problem, I think. In fact, there's a lot of what a colleague, C.J. Peake, would say, a lexicon problem. We have a lot of issues with words. So if I say integrated care, that doesn't mean you know exactly what I'm talking about, or collaborative care, or patient-centered medical home, or the list goes on and on. So being able to, and so they just, and I'll show you some descriptions of those in a minute, but care enhancers, and that's what Antioch's particularly looking at, how do we get sort of more of those folks out there? Obviously, you noticed on that first one, primary care providers were not on those 3 lists. And their rationale for that is that there's already some workforce. In fact, there's a primary care workforce committee, a governor's committee that I've been on the last few years, really trying to advocate for the mental health part of that. So there's a lot of work looking at primary care workforce. So they didn't take that on as their charge. They were looking at those other 3 roles. So these are some of the roles that you may have some in your. So they got care manager, a care coordinator. How's a care manager different from a care coordinator? How about a navigator? How about a health coach? Community health worker? Patient educators? So all these are words that are used in different organizations and different settings, but all of them, they don't tell you. In fact, maybe if somebody could define each of those and have everybody in agreement here, that would be amazing. But I don't think that's going to happen. So then they looked at, this was a chart that they said, what do you have now? So the dots on the left, what you have on the left there is health coach, navigator, advocate, educator, the same roles. And they asked people, do you have the, what you need now? And that's what that left dot is. So for health coach, they said, sort of in the middle of that scale. Then the second dot was, what will you need, I think, in a year? Oh no, what do you have now? What do you want now is the second dot. And what do you think you're going to need in 5 years is the third dot on these different elements. In their agencies. Again, these are FQHCs looking at this. So his point was, it's hard to sort of, most of the 2 dots on the far side are right together. Like, what do we want now? What are we going to need in 5 years? That is very hard to think out 5 years in terms of what kind of really, that's my point, I think, around culture change. We're not very good at thinking that far out and kind of what could be a whole different model of how this is provided. And again, I think it's much more in the neighborhood. I'm going to skip through that one. So this is sort of about how do people get into primary care. So you get at the bottom there, a completion of a bachelor's degree, and you get some work experience, potentially. Make some money so your parents don't have to keep it. And then you have master's or doctoral training. And then you either get, in terms of working in behavioral health, in a primary care setting, you either placed there, which is part of your graduate training, or post-degree training. So most of what I talked about earlier is on the left side of that, and the right side is the post-degree. So people who are trying to transition, which is, I think, harder to do. I think right out of, if you're sort of really oriented to this and you get out of school and you want to do this, it seems easier to me than if you've been out 10 years and you're really into a mode of operating in a kind of mental health role, to change that and come back. We have a provider who's really passionate about this in our area over there and really wants to do this, but it's that creep back to that traditional role. And she had a caseload, has a caseload, of kind of people she'd seen a while. So it's very hard to transition, be respectful and do what's clinically appropriate with them and feel like she's accessible to the number of people coming in that need her services and the providers who are really looking for help kind of right there in the moment. So the training needs identified by this workforce need to have licensed mental health professionals, modules to introduce students to the field of primary care behavioral health. So on the website, these are all on the Endowment for Health website. Those first 4 programs to become a licensed mental health professional, taken while maintaining a full-time job. Specialized training models in pediatric settings. He says that's under development. So these are all things that have been identified as ways to get additional training. The last one there, they're experiential placements for these folks, and you may be familiar with some of those. So there's a HRSA grant that have at Antioch for doctoral psychology students. There's one at UNH for social work and occupational therapy students in master's programs, and we've placed some of them in primary care settings. These are all, the focus is to provide some of the training I've been talking about. So there's HRSA and the federal government looking at, again, at the VA and the DoD is going, how can we stimulate more training in these areas? There is the community college system, I think, has one of them, and Plymouth State College has one in their MHC program. So there's money in the state to provide some of this training. It's a long-term strategy, again, because there's not going to be probably enough coming out, I think, to be able to provide it. So that's, again, the reason to look at the other workforce, the MAs and so forth. So looking at care enhancers, the more teams work together in the flow using huddles, programming for complex patients. He says, I call it meta-integration, nobody else calls it that. So I'm not sure exactly what he's talking about with this, but really, in terms of really building up the care enhancer workforce. Ken?
Bill, just curious, I don't see anything in there about suicide prevention training. And with suicide rates rising, second leading cause of death, ages 10 through 34 on the state, and and close moving on up, fourth leading cause of death, age 54. Where's the training, number one? Can you talk a little bit about a zero suicide approach for primary care, number 2? And number 3, what's the overall role of primary care providers in preventing suicide deaths? And I would add to question number 1, sadly, people aren't getting suicide prevention training in their master's programs either. And so if they're not getting it there and they're not getting it when they're coming to work in primary care settings, where are they getting?
Yeah, well, it's a good point. It's not up here explicitly. It should be. It's probably assumed by both of us that they are getting it in their master's programs. But that is, you would know that better than I, whether that's actually happening. I think in terms of your question about the role, I know, and Nami and Elaine has developed a module for primary care providers that I've looked at, and part of, I think, to make them more comfortable being because they're often going to be the front person. I think MAs and nurses certainly are going to hear things and know families more to be able to involve behavioral health folks. I think the difference in role is they're going to be much more, should be much more involved in the planning, much like ESPERT or anything else. I'm not trying to equate them, but I think that being able to be part of a team that says, how do we as a clinic approach suicidal ideation, suicidal behaviors?
Well, it's screening.
And screening.
There's a lot of data that indicates that people are coming to primary care providers with medical concerns and not disclosing their suicidal thoughts and taking their lives shortly after seeing a primary care provider.
Yeah, I don't know if in this state, maybe somebody has examples, but I know with the PHQ2 has become this kind of, somewhat, has pros and cons, but it's certainly been out there used a lot as kind of, here's our screening for depression. A lot of clinics now are adding the suicide question, so to make it a PHQ-3 and being able to do something with that information. So I think there is, I'd like to see movement in that direction. I know, I'd certainly be glad to talk about how, with the IDNs, how we could do that, how we could partner even more about doing that. Mr. Silverberg.
Ken and I can talk more offline. Across the FQHCs, starting about 5 years ago, we all started to do PHQ-2. That's positive, we do PHQ-9. That's positive, we do suicide. And the primary care providers are in on that. Usually those are administered by the nurses initially. When they get to the PHQ-9, it usually is the behavioral health staff. The suicide assessments usually.
So PHQ-2 to the PHQ-9, and then doing a suicide assessment after that.
Right. The other thing that goes on is that we have different ways of doing it different places. But all of us have had periodic suicide training for the staff. It's usually the behavioral health staff putting it on for the other staff. So we've got one coming up on January 3rd.
The behavioral health staff providing that training internally with the
staff.
Yeah, I think it should be a role to not only, they need to learn about it themselves first before you can sort of train, other folks to be able to do it. I think that's not that seems like a viable model to do it though. I think but specifically as a role to be part of what they do. Okay, so the last thing, I'd just like to give you a little bit of an exercise talking together. We'll just group up in groups of 3, but I want to show you, so here are some definitions that came out of what is a care coordinator. So you can see this kind of list. Here's a patient advocate, a lot of overlap to these, right? Here's a navigator. So these are right off and here's a health coach. Here's what a health coach does. So all these are examples of people that are called this, and in general in the term care enhancers. So if you could just for 5 minutes or so talk with just a couple people around you about what would you expect of a care enhancer? What are the competencies needed for somebody to do this, and what would be the impact on patients? Just talk for a little bit about what do you think the core competencies in your group, the top 3 core competencies of this care enhancer position, whatever you call it. What is it? It's not what you call it, it's what they do. What is it that you feel like they really need to do? So about 5 minutes? So let me go back to Ken's question about how many people went to Exeter Hospital put on a zero suicide conference 2 years ago, was it? Anybody was there? Yeah. It was probably one of the best conferences, best trainings I think I've ever been to. And it really, I think that's the kind of effort I think that Ken, you're talking about. There were, I think, 10 or 12 different organizations with their teams there. So it fit. There were behavioral health folks, there were physicians, there were administrators. So they were sitting around tables talking, what do we do around this? And they were charged with coming up with projects, which I'm hoping most of them are moving forward with. So I think more of that, I think, is the kind of training. And so I totally agree with the addition of that as a role. And it's a critical need in behavioral health. So Sandy was going to write some of these down so that we could pass them back. So what came up? What are the roles in terms of care enhancers? Back to that question. What competencies? What's really needed? Yeah.
Start.
Yeah, 1 or 2.
So we had a great
great discussion here, and the first thing that the group came up with was relationship building, patient and provider relationships. So it would be building that relationship, and then identifying the common language, so assisting in building that common language, and then working to build a plan. So those three things.
Great, thanks. Yeah, building a relationship, community health workers particularly, those, from the community really. Some navigators, they call them up north, in North Country, but it's a key element, I think, of the team. Who else?
Correct me if I'm wrong. We talked about the basics there, motivational interviewing skills, recognition of suicide, risks, factors, knowledge of that, and so that there's an ability to recognize that, and knowledgeable about the social determinants of health. So I'll go with those.
So no matter what you call them, those are the kind of expertise that they would have and the things they would sort of bring to the table. Motivational interviewing, is often seen as a set of skills, you learn these. I think it's much more an attitude. There are skills involved, but it's an attitude of, I'm not the expert, you are, and how can I help you do this? So without the attitude, you can have all the skills in the world, and it's not going to, all of a sudden, you revert back to the expert. So that's a great, and another one to infuse a culture with of how we approach that. So. Who else? Got another one?
So we hit on the relationship building, and then we also talked about knowing the resources in the community, and really being able to make recommendations kind of on what's going to work best for the individual and how different organizations operate.
Great. Yeah, knowing the resources, but also knowing what's going to fit and what somebody is ready for at any particular point in time. I think that is, I think that's a key role of these, for sure, because we know that social determinants and figuring out, I think one of the things we struggle with a lot in all of our work is, we refer out to an agency, but do we know what happened with that? Sometimes we do, sometimes we don't in some systems. There's what's called known as closed loop, if you will, trying to figure out what happened and what, if it didn't work, what do we do? So I went back here and I'll come here.
One of the other things that we talked about was being a good advocate, both across the agencies and within the same agency. But that all the people in those enabling roles need to really advocate for the clients.
Great. I mean, I hope to come back with this to the patient and family, because that's where it started with this, and that's where it needs to sort of stay.
So I just wanted to add, to have respect for the care enhancers and compensation for those folks.
Done. Yeah, absolutely. Sort of falls into how we value teachers. There are a number of professions in our great. Thank you. Anybody else?
They cited it. It's available.
Thanks, Cindy. Anybody else? Okay, thoughts, questions? Any final thoughts or reactions before we?
Yeah. Just quickly, I'd like to reemphasize the importance of being visible within the primary care practice. If you're not seeing a patient, don't be sitting in your office. I think it's so important to be in amongst the medical team so you can have confidence in them and they can have confidence in you. Also, flexibility in your schedules, not to be rigid, not to be thinking you're going to be doing 45-minute sessions and 15 minutes for your notes. You've got to be available to do one handoffs, consults, and get your notes done when you have a no-show or a cancel. If you don't have that approach, and I think people like me have been at 30 years, it's hard to learn that approach and rethink how you do your practice. But if you don't have that approach, I think integration would be way
too difficult for you.
Yeah, no, absolutely, I think, and believe me, I need to be here, you know, I mean, I am a vital part of this, and you ask, you know, certainly primary care providers will, if they tried to take, if you provide a service and it's sort of working, if you say, well, we're gonna cut it out or cut it down, you know, there's a hue and cry against that, that's for sure, so. But I think it's hard sometimes to stay visible and be out there.
I'd like to go back to where you started. I have a big voice. I don't
Okay,
know.
all right.
And you talked about payer systems it being easier for Kaiser, for the VA to have truly integrated care because they were essentially their own payers. And I'm curious, aside from the CPT code issue, which I heard, what about that you think makes it easier?
Well, I just think it creates a relationship with the payers. The woman from Oregon, I was just struck by, she said, it felt like that she really knew the clinical world. She was a lawyer who was working for their CCO, the version of MCO, but knew all of the clinicians and knew what they were trying to do, had been to the clinic, had seen what was happening. And I think that relationship is what made it seem, you know, not that they didn't still, you know, argue about how much for this and that, but it felt like they were in it together. And I think that's sometimes I think what the difference can be. Now, not to disparage our MCOs who I think do everything they can, but it was something that about that. I think that's what you know, that's what makes a difference in their deciding together about sort of what's going to happen. Yeah.
One of the reasons we're able to do so much of that in the federally qualified health center is because the payment structure, especially for Medicaid and Medicare, is great. It includes the coordinated care. But you're also able to negotiate those now with some of the payers. And we've got 2 contracts with MCOs where we've been able to integrate that into the pay performance part of the program. And it requires communication.
Yeah, that's good. All right, well, I think we're about at time. Thank you very much. I really appreciate it. Any questions later?